Hello, everyone, and welcome to the Pop That Mama podcast. In this episode, we have the incredible Dr. Melanie Jackson. We're going to be talking all about giving birth in the system, what you need to know, and how to set yourself up for a great birth experience. As always, guys, get yourself a cup of tea and enjoy. Ugh, it's lovely to see you. I won't pretend that we haven't already been talking for 3 hours, but for our lovely listeners, why don't you introduce yourself, Melanie?
Yeah. Well, I'm Australian, as you might hear from my accent, and I'm a midwife here in Australia, a private midwife. So predominantly I attend women who are planning home births. I have a podcast called the Great Birth Rebellion podcast, and some people might know me as Melanie the midwife. That's my sort of social media presence. What else do I do? I'm a mum of two. And oh, they call me Dr. Melanie Jackson, not because I'm medically trained, but I have a PhD in midwifery. And so, yeah, that's what I do. I'm pretty sure that's me in a nutshell.
Yeah, you have also been doing some amazing work on social media. I see your clips coming up a lot now. And guys, do check out her podcast, it is incredible. But today we've invited you on to talk all about the system. This is a question that comes up a lot in my DMs and certainly in the village community that I have. Why is it that intervention rates are so high?
Well, if we think about how birth is set up, how the majority of women are funneled into this central location to have their babies. There are a few countries around the world who have higher percentages of women who are giving birth at home or in birth centers. But the vast majority are encouraged to go towards this central location and have their babies within facilities. And the main reason for that is that's where all the health professionals are huddled, ready to receive women who want care during their birth. Now, the problem with that is that when you have all these people in a space, all hoping to have great outcomes for women and their babies, there has to be a plan and a strategy of how we're going to care for this many women in this facility with limited resources, limited staff, limited time. We have to have a system for dealing with the number of people who are going to come through and need care from us. And the stakes are high. We need to keep everybody as well as possible. So there has to be a clear set system and a clear set of rules. Now, this is not dissimilar to when you set up, and this is going to sound terrible when I say it, but hear me out. When you set up a factory that has a function, you have to have clear processes, clear pathways, and clear instruction for all the staff because it's a huge machine required to do something probably quite complex. And then at the end of the experience needs to pop the product that moved through the factory. And the product in a maternity care system is women and their babies. So why are interventions so high when birth is managed in these institutions? And that's because birth has to have some really clear boundaries that everybody agrees on. Because everybody's providing this kind of hopefully streamlined care, and then they're passing women from one part of the conveyor belt to the next. And that next person who receives that woman needs to be aware of, what she's gotten from the last. And that requires everybody to follow a sort of a clear set of rules. And so there has to be boundaries on what is normal and what is abnormal. And then if women step outside of the normal expectation of a laboring woman's body, then the approach is to intervene, bring it back on track. It's come outside of the boundaries of what's allowed, of what we consider normal in this facility. We need a strategy for bringing this labor back on track, back within the realm of what that factory and those workers believe is normal. So if you think about something like time in labor, you might go into hospital and let's say you've been laboring for longer than 12 hours and your cervix is not dilating as fast as they would expect. The intervention that's going to be offered to you to bring your labor back on track, to conform back into that expectation, is that they're going to offer you some artificial oxytocin to augment and speed up your labor so that your labor complies to the expectation of that facility. And so interventions are offered to women to keep them within the boundaries of what the medical definition of normal is for labor and birth. The problem with that is that the expectations that are put on women's labors by a medical philosophy don't match what physiological birth actually normally does. So long labors aren't necessarily pathological, but they're pathological in a medicalized context, and therefore interventions are offered to kind of fix that pathology. I mean, I could talk about this all day, like why are interventions offered? But essentially, they're offered to bring women and their labor experiences back into the realm of what medical establishments believe is normal about birth. The problem with that is that our bodies so often don't fit the medical definition of normal that we've been giving increasing levels of intervention to try and get our bodies to conform to what medicine says they should do in labor. But birth doesn't act that way. We've misinterpreted how birth should be, what normal birth is. That seems to have been forgotten. And so intervention after intervention is trying to force birth into like a place it isn't gonna go.
Gosh, that's such an interesting way of explaining it. And you're absolutely right, because if we imagine trying to write a textbook on birth, explaining physiological birth, and you said, well, labor could last 1 hour, 40 hours, who knows, pushing could last half an hour, 5 hours, placenta could last, people would find that really hard to kind of cope with. We need some sort of framework, don't we? And so I've never heard of it explained in that way, that we're trying to fit women into this kind of way that the medical system perceives birth to be. Okay, you're dilating an hour, 1 centimeter an hour, whatever it is. And then when we fall out of that realm, then we're perceived to have a pathology, which then we need interventions to put us back on that same path. How interesting. Could it also be that we desperately want things to be safe, and so we should? So during pregnancy, women are having lots of tests and procedures that then could produce false positives. So if we give everyone the glucose test, or we measure everyone's blood pressure, we're going to see variations of normal. But if it falls out of the framework, then that could be treated as a pathology, but it may not be. Could that also be impacting the rate of intervention?
Absolutely. I mean, maternity care providers are well-meaning. They genuinely go into their work thinking, I want to prevent as many complications as I possibly can and keep women and babies as safe as I possibly can. But it's based on a flawed premise of our definition of what is safe and what is risky. We want to classify risk. We want to predict potential outcomes and discover potential risks so that those risks can be mitigated. Like fundamentally, that's a noble task. Hey, imagine if we could apply a test, discover a risk, offer an intervention that mitigates that risk, and then, hey, we've theoretically kept women and babies safer. The problem is that when you over medicalize the process of pregnancy and birth, all of a sudden you might find a problem. So let's say, you've had an ultrasound and you're in your third trimester, and they say, right, your baby by this ultrasound is big. Therefore, you're at risk of shoulder dystocia, hypothetically, but this is the medical way of thinking. We're going to offer you an induction to get the baby out, because the longer the baby stays in, the bigger it'll get, the higher risk of shoulder dystocia. And that all makes complete and total sense, except when you discover how potentially inaccurate growth scans could be. So, up to 30 to 40% might be accurate, but outside of that, it's very difficult to determine which growth scans are accurately determining the baby's weight and which are not. There can be a 10 to 20% discrepancy, and even more the longer you're pregnant. So then we're basing the decision to have an induction off a flawed test that doesn't have a great predictive value of which babies are actually big and which babies are not. And then we've induced you at an earlier date than your body was going to go into labor. And then the baby comes out a beautifully healthy 3.7 kilos. And everyone goes, oh, well, there was no shoulder dystocia. Everybody's fine. We did a good job. Except that that baby was never big to begin with. We made a big clinical decision to intervene in this pregnancy based on a flawed screening strategy, and nobody asked any questions about that. And then the woman is like, oh, well, I didn't like that induction. I actually didn't want it in the first place. Now my baby's actually perfectly normal size, and I had this unnecessary intervention to begin with. And there's this whole rollout and impact on the woman and potentially her baby, because there are risks to every single intervention. It's not a risk-free scenario. There are risks and benefits. When you intervene, you introduce new risk. You could also introduce new benefits, but none of that can be determined ahead of time. That's all in hindsight. So the screening tests are not 100% accurate. There's a wide, vast range of screenings that you could have: gestational diabetes, GBS screening, the size of your baby, all these things. The process just falls down at so many points that it's very hard to know if the intervention is appropriate for that woman's circumstance.
And we're not having that conversation about, okay, so what happens when we get false positives? For example, I know the big thing is the CTG machine, continuous fetal monitoring, which, I know in the States is actually being used for low risk women, even though the World Health Organization says that you shouldn't use it for low risk women because it increases the chances of cesarean. But isn't it interesting how these things are, perceived as safe? I can so easily see that, of course, monitoring the baby's heart rate, hearing that sound for the woman can actually feel safer despite all the evidence. And isn't it interesting that in medicine, once something comes in, it's so hard to get it out, even though you've got all the proof that it's not working.
And it's so interesting with the CTG issue. Kirsten Small, who works under Birth Small Talk, she is a retired obstetrician and she did her PhD in the use of CTG. And what her PhD discovered is that there is, she calls it 1.5 circumstances of when CTG is an appropriate thing to use. The one circumstance is if the woman absolutely wants it, and the half a circumstance is during induction, because an induction carries increased risk to the baby. And what they found is that if you have an induction with a CTG versus one without, you're more likely to capture a baby who's struggling as a result of that induction. Outside of that, there is zero evidence that CTGs improve outcomes. In fact, in some scenarios, they found that they worsen outcomes, particularly with preterm birth. They find that the babies who have a CTG on during preterm birth have poorer outcomes than the babies who didn't have CTGs. And that's across the board with all the other scenarios. So there is so little evidence on CTG usage in terms of improving outcomes for babies that it's laughable that we even use it. But the problem is that it's so embedded in maternity care culture that it appears to be now unethical not to offer it to women, even though we don't even know what a normal fetal heart rate is during labor. Nobody's done the studies to work out what's a normal fetal heart rate, and then how do we know what that fetal heart rate looks like when it becomes abnormal? We've made a whole lot of assumptions, but they appear not to be accurate because they're not actually improving outcomes for babies in most scenarios.
Gosh, as a doula, the most common scenario that I witness where a mum has had to have a major intervention has been the heart rate. I mean, so many times. Baby's tired, heart rate's going down. Heart rates are non-reassuring. And I know in the US, non-reassuring heart tone is the second most common reason for cesarean. So that's quite shocking, isn't it? That we're not going, hang on a minute.
Yeah,
and
and
it's
that's
that.
not to say that, we shouldn't be monitoring babies' heart rates. What we're saying is that intermittent auscultation seems to be just as effective at picking up babies who are struggling as a CTG would be. However, the
Yes, yes.
intermittent auscultation doesn't have the downside of increasing intervention rates as a result of its use. CTG seems to create an overreaction in care providers, which doesn't seem to happen in intermittent auscultation so much. But intermittent auscultation with the Doppler is still an effective way of determining if a baby is not doing well based on their fetal heart rate. If I'm caring for a woman who's having a VBAC and the baby's heart rate's super duper high, I'm thinking, okay, some alarm bells here. Are we experiencing a rupture? Is something happening with the placenta? Is the baby stressed? But I didn't need a CTG to determine that. The Doppler is effective. But using a Doppler requires a level of human interaction also that the system might not have the resources for. It's really easy to strap a machine onto somebody, get a readout and a record of what's been happening in your absence, not have to hold that on and be physically present, than come in with a Doppler, enter a woman's birth space, interact with her, hold it on, make a human sort of conclusion about if that heart rate is normal or not normal. It's like it's a whole different experience.
Yeah.
And so I think the use of CTGs, it's a symptom of the disconnection that's happening in maternity care at the moment.
Thank you for clarifying those two options. And yes, the the CTG is definitely more convenient and easier because how often is it? Is it every 10 to 15 minutes, the
Yeah, if you go
intermittent
by
monitoring?
the research suggests they haven't done a whole lot of research on any kind of fetal monitoring, but every 15 minutes seems to be the professional
Yeah.
standard
So that
for checking.
requires a hands-on present midwife that isn't, overly stretched and hasn't got multiple women to attend to. Also, in terms of, when you have a CTG, you have a printout, don't you? And it can be used as evidence potentially if there were ever a court
Yeah.
case. So there's also perhaps that at play, is that from the healthcare professional's point of view, that is going to be better in court, is that you have a trace.
Potentially. And what the CTG represents is the culture of surveillance that exists within a hospital. And so not only are we surveilling the baby, but I don't know what it's like in the UK, but here in Australia, there's policies around the senior midwife coming and checking the CTG trace if there's another midwife in the room, and that's also about surveilling the work of that midwife. Has she let anything slide? Did she not recognize something? Is she hiding something? Did she take it off? Is this baby really doing well, or is it distress and the midwife hasn't recognized that? And so then midwives become vigilant to keeping CTGs on and getting good contact and reading them and making sure they haven't made a mistake because they know that somebody else is looking over their shoulder and checking their work. And then even more so now, there's this central fetal heart rate monitoring coming in where all of the CTG traces are being beamed out to the front desk and everyone can see them. And then the minute something looks odd on one of the traces, somebody completely unbeknownst to the woman and the midwife storms in thinking there's this huge emergency going on. Well, maybe the woman's taken it off and gone to the toilet. We don't know what's going on in there. And so actually it becomes a representation of the over surveillance that's going on in maternity care, not only of women and of babies, but also of midwives who are working in the system. And they feel like because they're being watched, they have to behave in a particular way. And this is certainly where the research is around CTG use and particularly central CTG monitoring, is that it's less about safety and more about surveillance, but also more disconnection. Because if you're caring for that woman with a CTG on and you can see the trace from outside of the desk, you don't even have to go in. And it's just a symptom of a bigger systematic issue, I think, in maternity care.
So it's again up to the woman now to take control, look at the evidence, and make an informed decision around either the intermittent monitoring or the CTG, if you're being induced, maybe if you're high risk, Or again, like you said, if that is what you want. Let's take a step back, and I want to ask you about the different philosophies towards birth that you see as a midwife.
Yeah. So I think I call this the medicalization spectrum, and it's certainly something I talk about in my Great Birth Masterclass, is understanding this medicalization spectrum and where you sit on it, and when your care provider sits on it, and where your partner sits on it, and where your birthplace sits on it, can help you align all of those things together. And I think aligning all of that onto the medicalization spectrum and to yourself is the first, like, sort of key part of having a satisfying birth experience. So, if we think about the medicalization spectrum, on one side of that sits this belief that childbirth is a physiological function, that our bodies were made to do it, that most of the time it works well. It's kind of the natural birth philosophy, if we're going to give it a name. Women who have this philosophy generally have less fear around birth, and they want fewer interventions, they want fewer medications, they want to just see what their body's capable of, what their body can do. And then it's a sliding scale all the way along to the most other extreme end, where somebody believes that childbirth is inherently dangerous, it goes wrong all the time, it needs heavily supervised care by a medical clinician who can give surgery at any time because often that's going to be required. On that biomedical philosophy, that says you're in a pathological state, you need constant medical supervision, you're a ticking time bomb. Things could go wrong at any time. Everyone could die at any minute. So we need to really, really watch this. And that philosophy is really governed by a sense of fear and urgency. Is that, whoa, birth is scary. It could go wrong at any time. I need to be in a hospital with medical staff who, at the drop of a hat, could give me a life saving intervention. Now, those are the two extreme ends. You know, there is another extreme end where people are like, birth never goes wrong. It always works out. We don't need healthcare providers. That's one extreme end. As it's as false as the narrative of birth can always go wrong. It's always dangerous. You always need a medical provider. Those are the two extreme ends. Most people exist in the middle along the spectrum where those two philosophies interact. Now, women can have an idea of childbirth that sits in along that spectrum. Midwives also have their own philosophy of where they sit on the spectrum. There are some very physiologically minded midwives. There are some who are incredibly medically minded and who work in that way. In the same way as we usually expect doctors and obstetricians to sit at the very medical end of things, but there are a few of those amazing, dark horse unicorn obstetricians who can very easily slide all the way down to the other end of the spectrum, believing birth to be quite a physiological event that they very rarely need to intervene in. So you've got your position, the position of your midwife, the position of the obstetrician, then the position of your partner, and whoever else you invite into the space, your doula, your mum, your friend, your whoever else is coming to support you. So imagine a scenario where you have a fundamental belief that birth is normal and natural and mostly doesn't go wrong. But then you go ahead and hire an obstetrician who believes that most of the time birth goes wrong and you need to be in a hospital with high acuity care. There is a profound mismatch in your philosophies, and neither of you are going to be satisfied in this relationship. You'll constantly butt heads, you won't understand each other, the conversations won't make sense, you'll all feel like no one's listening, and at some point, someone has to budge. And usually the woman gets encouraged to follow the path that the doctor thinks she needs to follow. Alternatively, imagine if a woman comes in and thinks, I want every intervention under the sun. I want an epidural. I want an episiotomy. I want you to vacuum that baby out. I want whatever it is they have on their mind. And they get placed with this beautifully physiologically minded midwife who's there to give you a medication-free birth and help you get in the pool and massage your back and put on your hypnobirthing tracks. Again, Total mismatch. No one is going to be satisfied in that scenario. Birth satisfaction and sort of the idea of this that you can have a great birth, the initial elements are aligning your philosophy with the philosophy of your care provider, and then also trying to somehow align your philosophy with your partner who may be either very scared of birth or not scared of birth at all, but you might also be plotted at different parts of this spectrum where the very first task is to identify where do you sit, where does your partner sit, and then it's about choosing a care provider that as closely aligns to your philosophical position as possible. Then you start to plot the birth locations because they also each align to a particular philosophy. So the women who fundamentally believe that nothing goes wrong in labor, it always works out so long as the ingredients are right, you can understand why they might think, for example, free birth is a great idea. Because they might have a feeling that every time you introduce a healthcare provider into that scenario, that something's going to go wrong. Because if you leave birth alone, it just goes fine. So they go, well, I'm going to have free birth. I'm not having anybody with me. That's one end. Then you move along to home birth, where the woman thinks, right, most of the time birth goes well, but sometimes there can be that complicating factor. I'm going to have a home birth with a midwife. They're skilled enough to deal with this physiological scenario of birth. And so then you move along. Birth centers again sort of sit more in that physiological philosophy. Then as you start to move into hospital, that setting has more of a biomedical philosophy. So immediately if you're a woman who really has an intention for a low intervention birth and you arrive to hospital for your birth, you automatically know that there is some malalignment in your philosophies and there's going to be some potential tension around that you're going to have to navigate. And that's okay. You can still have a great birth in that setting, but you first have to acknowledge that there's a mismatch and realize where the great might be on that, where there's going to be a bit of rub. And you think, how am I going to navigate that when there's a rub against my philosophy? And that could be, for example, like, well, I know there's going to be a bit of rub. I need to prepare my partner and I want to take a doula. And maybe if I can get on the midwifery group practice program, for example, if I have my own midwife when I go into hospital, there's all these little protective barriers from that medical philosophy that exists just by being in the hospital. So there's lots of things you can do to mitigate the challenges that occur when there's a misalignment. But if you don't first know that there's a misalignment, you can't be prepared. And it's the same reason if you want an elective cesarean section, don't go and hire a home birth midwife who doesn't have access to the hospital system. You're going to be dissatisfied. You've got to find that alignment. And so when I talk about the two philosophies, like they aren't starkly black and white, they exist along a spectrum, and every element of birth exists along that medicalization spectrum.
This sounds like real strategic birth prep. It really
Uh-huh.
does. And I think this is what you're bringing to the space that we don't have, which is thinking of things in this way, in multiple layers, and really like getting your head around like what you're up against. And
Yeah.
so tell us more about that. Why are you so passionate about preparing for birth in this more strategic way?
Yeah. Well, and I think doulas would understand it and midwives understand it. You can see the broad picture of how the system works, and we can understand the elements that go into things. But I feel like women aren't given that story. They don't get the bird's eye view of the system so that they can understand what they're coming into when they engage with the system to have their babies. It's such a huge and complex cultural situation that I feel like women find out the hard way is that they come out of their birth and have all these realizations of how the system works and wished someone told them ahead of time so they didn't have to learn the hard way by having maybe a dissatisfying experience or a traumatic birth or an unwanted intervention. and not being prepared to defend themselves or even knowing they would have to defend themselves. So, the thing that really motivates me is that I, and you would as well, have inside information about how the system works. And when you can understand how the system works, you can learn how to navigate it to suit your own purposes. Instead of being swept up in that and all of a sudden getting the birth that the system wanted you to have, you can create and navigate a strategy that tips the odds in your favor. That you think, right, I know I'm going into this scenario that might not be ideal, but I've got some strategies that are going to allow me to navigate and maybe manipulate that system to get what I want. And that is where birth satisfaction sits, is where women feel like they had enough information to make informed decisions so that they could be the chief decision maker of their birth. In fact, it doesn't necessarily even matter how it goes. If she had an unplanned cesarean section, but in the moment she decided that that's what she wanted and needed, she's going to be a lot more happy than a woman who feels like she was dragged and coerced into an intervention that she didn't want or a cesarean section that she didn't want. So I'm inspired to tell women about how the system works because I think it helps to rebalance the power dynamic that happens where when you go into a hospital, you are in medical territory. They immediately have more power than you because they understand how the system works. But then if you know how the system works, then all of a sudden you've gathered some power. And I think as much power can be given to women in childbirth, we're going to see way better outcomes, at least on an emotional level.
Gosh, thank you for everything you do. It is just so important for women to understand this. And you're right, there will be lots of women who have had challenging births, who have been in the system and had that kind of conveyor belt of care, cascade of interventions type of birth. And they're going, yes, yes, they really get what we're saying. And then there'll be the first timers who will go, whoa, this is a lot. Okay, I've got so much to learn. So you talk about having a great birth. What can the listeners do to set themselves up for a great birth, especially if they're birthing in the system? What can they do after this podcast to set themselves up for something positive?
Yes. I can give you like a 5-minute rundown, but ultimately there's a lot of work to do, and I wish I didn't have to say that. I wish I didn't have to say to women, actually, you are responsible for setting up the pieces that are required for a great birth. But the reality is that nobody is more invested in your birth experience than you are. And so we need to get into the mindset of I am responsible for putting together as many pieces of my birth as I can, for controlling and influencing as many factors as are within my power to control so that you get the best chance at having a great birth. You can't guarantee it. There are uncontrollable elements. There are so many things within our control. So I am doing a 2-hour masterclass guide to a great birth.
Amazing. And if they're listening post masterclass live, could they still pop their email in and get the recording?
Yes,
Okay, great.
absolutely. So if you go to melaniethemidwife.com,
I'll put it in the
you'll
show
see,
notes.
yes, melaniethemidwife.com in the show notes, you'll see Guide to a Great Birth Masterclass will be up there, even if it's beyond the date, and you'll be able to watch the playback.
Amazing.
Right, so that's free, but I'll give you a 5-minute rundown. So the elements are the place you choose to give birth at, the people who you choose to give birth with, and how much time you invest in understanding and learning about your options so that you can make an informed choice about what you're going to get. And choosing the right people and the right place, I'm putting that in inverted commas, it's an individual choice, not only based on your philosophical position, but also your individual needs. So some women have risk factors and they need a doctor, but they also can manufacture other things in their journey that still will sort of anchor them to the things that they really, really want for their birth, even though they have other needs that sit alongside their desires. That's probably all I can give you in the minutes that I have left.
Well, don't worry, everyone. You can click on the link in the show notes, join Melanie's masterclass, and I'm going to leave your Instagram and your podcast, which I'm now like directing everyone to because it's so good. It's literally like a treasure chest of information. I think someone could go from number one to, I don't know, you've got hundreds and just work their way through and actually, you know, find out so much and go on an incredible learning journey. So thank you for gifting the world this information. It's been lovely to have you. So just really quickly, where can people find you?
Yes. So melaniethemidwife.com is my website. At Melanie the Midwife and at The Great Birth Rebellion is where we are on Instagram. I'm on TikTok as Melanie the Midwife. You'll find me if you go to those places.
Amazing. Right. And hopefully we're going to invite you into the village membership for another chat.
Oh, I would love that.
Amazing. All right. Bye-bye.